feeling buried under your medical revision notes for chronic lymphocytic leukemia. Maybe like they're multiplying faster than the leukemia cells themselves.
Ha. Yeah, it can feel like that, but don't worry.
Well, you're definitely not alone. This deep dive is designed to be your shortcut through all that information.
Exactly. We've gone through a whole load of CLL revision notes and basically pulled out the absolute must-know stuff.
Right, the high-yield essentials. Think of this as your focused guide to getting your head around CLL.
Our mission here is pretty simple. Make CLL clear. We're going to walk through it all. You know, what it is, what might trigger it, who's more likely to get it, how it affects the body.
What else it might look like, the stats, how patients present.
How we investigate it, the treatments, prognosis, and the potential complications down the line.
Consider it your structured journey through everything crucial for understanding CLL. Let's dive in.
Let's do it.
Okay, first things first. What exactly is chronic lymphocytic leukemia? Give us the headline.
Okay, so in simple terms, CLL is a cancer of white blood cells, specifically a type called lymphocytes.
Lymphocytes, right.
And the key characteristic is this slow, steady buildup of abnormal lymphocytes. You find them in the blood, the bone marrow, lymph nodes.
And chronic is key here, too.
Absolutely. It develops and progresses over time. It's not usually an acute thing.
Gotcha. And these lymphocytes, what's wrong with them?
Well, it starts with one abnormal lymphocyte that just starts cloning itself over and over. We call that a monoclonal proliferation.
Monoclonal.
Yep.
One original faulty cell.
Exactly. And in like 99% of CLL cases, these are B cells, you know, the ones that normally make antibodies to fight infection.
Okay, B cells. But what makes them cancerous or problematic?
Well, here's the tricky bit. Under a microscope, these CLL lymphocytes can actually look pretty normal, mature even. But the problem is they're functionally immature. They don't work properly.
So they look the part but can't do the job.
Precisely. Which means the immune system is compromised, leaving the body vulnerable.
Right, that makes sense. How common is CLL then?
It's actually the most common type of leukemia found in adults. And it mainly affects older people.
The most common. Wow.
Yeah, it accounts for about a quarter, roughly 25% of all leukemia cases diagnosed.
Okay, it's a significant number. So how do clinicians definitively diagnose it? What are they looking for?
The main diagnostic criterion is finding a sustained high count of monoclonal B lymphocytes in the blood. Specifically, it needs to be equal to or more than 5,000 cells per microliter, and that count needs to persist for at least 3 months.
5,000 for 3 months. And monoclonal is key.
Absolutely. And you confirm that monoclonality using a test called flow cytometry.
Flow cytometry, right? What does that do?
It's a lab technique that identifies specific protein markers or antigens on the surface of the cells. It confirms they're all identical B cells, the CLL clone.
Okay, and anything else, like in a blood smear?
Yeah, when you look at the peripheral blood smear, you often see lots of these small, mature-looking lymphocytes.
Okay. 5,000 cells, 3 months, flow cytometry confirmation. Got it. Now, the why. What causes CLL? What's the etiology?
Well, that's still a bit murky, to be honest. We don't know the exact cause.
No, single smoking gun.
Not really. It seems to be a complex interplay between genetic predisposition and environmental factors.
Nature and nurture again. Let's start with genetics. Any specific genes involved?
Yes, certain genetic mutations are definitely linked. Changes in the TP53 gene are important. That's a gene involved in DNA repair and telling damaged cells to die. Mutations there are linked to more aggressive CLL.
TP53, always a key player in cancer. Anything else?
Yeah, mutations in genes that regulate the cell cycle, how cells grow and divide, are also implicated.
Okay. And the environmental side?
Yeah.
What factors are suspected?
There's some suggestion that exposure to certain chemicals, maybe some agricultural exposures like pesticides or radiation, could increase risk, but the evidence isn't as strong or clear-cut as the genetic links.
So genetics might load the gun, environment maybe pulls the trigger sometimes, but it's not fully mapped out.
That's a good way to put it.
Okay, moving on to risk factors. Who is most likely to develop CLL?
The biggest risk factor, without a doubt, is age. It's predominantly a disease of older adults.
How old are we talking typically?
The average age at diagnosis is around 70.
70. Definitely something to keep in the back of your mind with older patients. What else increases risk?
Family history is a big one. If you have a first-degree relative, so a parent, sibling, or child with CLL, your own risk increases quite significantly.
How significantly?
About 7-fold. So there's clearly a hereditary component for some people.
7 times. Wow. Okay. Any other factors?
Gender plays a role. Men are more likely to get CLL than women.
Men more than women. Interesting.
And as we touched on, having specific underlying genetic abnormalities or mutations even before CLL develops can be a risk factor.
So key risks: older age, family history, male sex, and certain genetic features.
Got it. Now let's zoom into the mechanism. What's the pathophysiology? What's actually going wrong at the cellular level? Okay, the core problem is this uncontrolled clonal expansion of mature B cells that are dysfunctional.
Right, the ones that look okay but don't work.
Exactly. One faulty B cell starts multiplying, and its clones just keep accumulating.
And why is that accumulation bad?
Because these abnormal cells build up in the bone marrow, blood, and lymph nodes, they crowd out the normal, healthy blood cells. And critically, because they don't function properly, the immune system is weakened.
Leading to infections and other issues.
Precisely. It disrupts normal immune function quite significantly.
And what drives this runaway growth? Why don't they just die off like normal cells?
It comes back to those genetic mutations and also problems in the cell's signaling pathways. These pathways normally control cell survival, proliferation, and death apoptosis. In CLL cells, these signals are dysregulated. They essentially get signals telling them to survive longer and keep dividing, while ignoring signals telling them to die.
So they're dodging the normal cell death process.
In essence, yes. They have enhanced survival mechanisms.
Okay, so if a patient presents with symptoms suggesting CLL, what else could be going on? What are the main differential diagnoses?
Good question. You always need to consider other things. Other types of leukemia, for sure, like acute lymphoblastic leukemia, or ALL, and acute myeloid leukemia, AML.
Other leukemias, okay.
Also, other lymphoproliferative disorders need to be on the list, things like various types of lymphoma.
Makes sense. What about non-cancerous conditions?
Definitely. You need to rule out reactive lymphocytosis. That's when your lymphocyte count goes up temporarily because of an infection like glandular fever or inflammation. It's a normal response, unlike the persistent monoclonal increase in CLL.
So distinguishing infection from malignancy is key.
Absolutely. And finally, sometimes other bone marrow disorders like myelodysplastic syndromes, MDS, or myeloproliferative neoplasms, MPNs, can have overlapping features, so they're part of the differential too.
Okay, a fair few things to consider. Let's focus on the UK now. What's the picture here? How common is CLL?
Right. So in the UK, CLL is, as we said, the most common leukemia in adults. The average age at diagnosis mirrors the global picture, around 70 years old.
And the gender split.
Again, more common in men than women here too.
How does it stack up against other cancers in the UK?
It accounted for about 1% of all new cancer cases diagnosed between 2016 and 2018.
1%. And any trends in age groups?
Interestingly, the highest incidence rates are actually in the 85 to 89 age group, and a large chunk, about 40% of new cases, are diagnosed in people aged 75 and over.
Wow, really skewed towards the older populations. That changed over time?
Yes, incidence rates have gone up by about 17% since the early 1990s.
Why would that be?
It's likely multifactorial, better diagnosis, an aging population generally, maybe other factors too.
And any differences across ethnic groups in the UK?
Yes, that's been observed. CLL incidence is lower in people of Asian and Black ethnic backgrounds compared to the white population in the UK.
Interesting demographic point. Okay, let's talk presentation. How do patients with CLL typically show up? What clinical features should make you think of it?
Well, a key point is that early on, many patients are completely asymptomatic.
So they feel fine.
Yeah, totally fine. CLL often gets picked up incidentally, on a routine blood test done for something else entirely.
An accidental finding. But when symptoms do develop, what are they?
The common ones include enlarged lymph nodes. Patients might notice lumps in their neck, armpits, or groin. Persistent fatigue and weakness are very common too.
Fatigue, okay. What else?
Getting infections more often than usual, easy bruising or bleeding, losing weight without trying unintentional weight loss night sweats, and sometimes a feeling of fullness or discomfort in the abdomen, often from an enlarged spleen.
That's quite a range. Any constitutional symptoms?
Yes, things like loss of appetite, anorexia, and weight loss fall into that category.
You mentioned enlarged lymph nodes. Any specific characteristics?
Yeah, in CLL, the lymphadenopathy is often symmetrical, so affecting both sides, and the nodes tend to feel sort of rubbery, not rock hard. Also, while chronic myeloid leukemia, CML, can cause lymphadenopathy, it's generally more pronounced in CLL.
Symmetrical rubbery nodes, good clinical clue. What about the abdominal fullness?
That's usually due to splenomegaly, an enlarged spleen.
Yeah.
The liver can sometimes be enlarged too, hepatomegaly.
And the bruising or bleeding?
That points towards thrombocytopenia, a low platelet count.
Yeah.
You might see tiny red dots, petechiae as well,
And the tiredness.
usually linked to anemia, low red blood cells.
Are there less common signs?
Less commonly, you might see skin infiltration, enlarged tonsils, or rarely involvement of the lacrimal or salivary glands.
Okay. Now, you mentioned incidental findings, but are there times when NICE guidelines say we need to investigate urgently?
Yes, absolutely. NICE has criteria for ordering a very urgent full blood count, meaning within 48 hours in adults.
What are those red flags?
Things like unexplained pallor, persistent fatigue that's unexplained, unexplained fever, persistent or recurrent infections without a clear cause, generalized lymphadenopathy, so swollen glands in multiple areas, unexplained bruising, bleeding, or petechiae, and if hepatosplenomegaly is found on examination.
So basically, any of those unexplained blood-related symptoms or findings warrant a quick FBC.
Exactly. They could indicate leukemia or another serious blood disorder.
Okay, so let's say CLL is suspected based on symptoms or that urgent FBC. What investigations are needed to confirm it and assess it?
The workup starts, of course, with the full blood count. That confirms the lymphocytosis, the high lymphocyte count, and checks for anemia or thrombocytopenia.
And the blood smear we mentioned earlier.
Yep. Looking at the peripheral blood smear is crucial. You're looking for those characteristic small, mature lymphocytes, and often those smudge cells.
Ah, yes, the smudge cells. Remind me of the memory tip.
Think of a fragile, tired lymphocyte getting squashed or smudged during slide preparation. It's not specific to CLL, but very characteristic.
Smudged eyeliner on a tired lymphocyte. Okay, what's the definitive test then?
Flow cytometry on the blood sample is essential. That's what confirms the lymphocytes are monoclonal B cells expressing the typical CLL markers.
Flow cytometry nails the diagnosis. Is a bone marrow biopsy always needed?
Not always for diagnosis anymore, especially if flow cytometry on blood is clear, but it's often done to assess how heavily the marrow is involved, to check for other problems, and sometimes for prognostic information. An aspirate might be taken too.
And a lymph node biopsy.
That's usually reserved for specific situations, like if one lymph node suddenly grows much larger, much faster than the others. That raises concern for Richter's transformation.
Richter's transformation. We'll come back to that. What about genetic tests?
Very important. Cytogenetic and molecular genetic testing look for specific abnormalities in the CLL cells, things like deletions or mutations. We always test for TP53 gene deletion or mutation before starting treatment.
Why before treatment specifically?
Because the presence of a TP53 abnormality makes a CLL less likely to respond to standard chemoimmunotherapy and guides us towards using targeted agents instead.
Crucial for treatment choice. Any other pre-treatment checks?
Yes, it's standard to screen for infections like hepatitis B and C, CMV, and HIV before starting certain immunosuppressive treatments.
And imaging. CT scans, ultrasounds.
Imaging isn't used for staging CLL itself, but it can be useful, say, to assess the size of the spleen or liver, or to see if bulky lymph nodes are compressing anything important.
Okay, comprehensive workup. Now, staging. You mentioned the Binet system earlier. Can you walk us through that again?
Sure. The Binet system is widely used in Europe. It looks at hemoglobin, platelets, and the number of affected lymphoid regions. Neck nodes, groin nodes, armpit nodes, spleen, and liver are the areas considered.
So stage A?
Stage A means hemoglobin is 10 GDL or more, platelets are 100 by 109 LO or more, and fewer than 3 lymphoid areas are enlarged.
And the mnemonic.
A is for almost normal blood counts and limited spread.
Got it. Stage B?
Stage B. Same blood counts as stage 8 HB10, platelets at 100, but now there are 3 or more areas of lymphoid enlargement.
So the mnemonic?
B is for burden of lymph nodes, more widespread lymphadenopathy.
B is for burden. Okay. And stage C?
Stage C is defined by the blood counts. Either the hemoglobin is less than 10 GDL or the platelets are less than 100 by 109L or both, regardless of the number of lymphoid areas involved.
So C is for cytopenias.
Exactly. Low blood counts indicating more significant bone marrow impact.
Are there other factors considered, especially in early stages?
Yes. Things like the absolute lymphocyte count, how quickly that count is doubling the lymphocyte, doubling time, the pattern of infiltration in the bone marrow biopsy, and whether it's a very slow form called smoldering CLL can give additional prognostic information.
Okay, staging helps understand the extent and impact. Let's talk treatment. How is CLL managed?
Right. Management is highly individualized. It really depends on the stage, whether the patient has symptoms, their age and overall fitness, and those genetic markers we mentioned.
So no one-size-fits-all approach.
Definitely not. It's a detailed discussion with the hematologist. The options range from just keeping a close eye on things, watchful waiting, or active monitoring.
Watchful waiting.
Yeah.
When is that used?
That's often the best approach for early-stage, asymptomatic patients. CLL can be very slow-growing, and some people live for many years without needing any treatment, avoiding potential side effects.
So you only treat when necessary.
Generally, yes. Treatment is usually initiated when the disease becomes active and causes symptoms, or if it progresses to a more advanced stage, or if the blood counts drop significantly.
And when treatment is needed, what are the options?
There's a growing toolkit. We have targeted therapies, chemotherapy, immunotherapy, often used in combination, and in some cases, stem cell transplantation.
Can you give some examples of current standard treatments?
Sure. For first-line treatment, options might include targeted therapy combinations like venetoclax plus obinutuzumab, or monotherapy with drugs like ibrutinib or acalabrutinib. For younger, fitter patients, especially without adverse genetics, chemoimmunotherapy like FCR, that's fludarabine, cyclophosphamide, and rituximab might still be considered.
FCR. Okay. What about patients with those high-risk TP53 mutations?
For them, chemoimmunotherapy is generally avoided. Targeted agents like venetoclax-based regimens or BTK inhibitors like ibrutinib or acalabrutinib are preferred upfront.
And if the CLO comes back, it relapses.
Management depends on how long the remission lasted and what the initial treatment was. If it's a late relapse, say more than 3 years after FCR, repeating it might be an option. But for earlier relapses or relapse after targeted agents, we'd usually switch to a different class of drug.
So lots of sequencing options.
Yes. And for relapse patients with high-risk features, an allogeneic stem cell transplant might be discussed.
Let's dig into the drug types a bit more. You mentioned chemotherapy. What are the main players?
Older chemo drugs include alkylating agents like chlorambucil, which was used a lot historically, and cyclophosphamide. Bendamustine is another alkylating agent often combined with rituximab. Purine analogs like fludarabine were key components of regimens like FCR.
And monoclonal antibodies?
These are immunotherapies. Rituximab targets CD20 on B cells. Obinutuzumab is a newer anti-CD20 antibody, and alemtuzumab targets CD52. They're usually given with chemo or targeted agents.
And then the targeted drugs. Venetoclax.
Venetoclax is really interesting. It's a BCL2 inhibitor. BCL2 is a protein that helps cancer cells survive, so blocking it encourages them to die. It's particularly effective in CLL, especially with TP53 issues.
And the others like ibrutinib?
Ibrutinib, calibrutinib, zanubrutinib, these are BTK inhibitors. They block Bruton's tyrosine kinase, a key enzyme in the B-cell receptor signaling pathway that CLL cells rely on to survive and grow. Idelalisib is another type of PI3K inhibitor, used less often now due to side effects.
So lots of ways to hit the signaling pathways. What about steroids?
Steroids, like prednisolone, are often used to manage autoimmune complications like hemolytic anemia or ITP. They can also sometimes be given before chemo to reduce lymphocyte count or improve marrow function.
Okay. And stem cell transplant, you mentioned allogeneic. Why not autologous?
Autologous transplant, using the patient's own stem cells, just doesn't work well in CLL. The disease tends to come back quickly. Allogeneic transplant, using donor cells, offers a potential cure because the donor immune system can help fight the CLL, the graft versus leukemia effect.
But it's intensive.
Very intensive with significant risk, so it's typically reserved for younger, relatively fit patients with high risk or relapse refractory disease. Deciding the optimal timing is complex.
Any role for surgery or radiotherapy?
Surgery is mainly limited to splenectomy, removing the spleen if it gets massively enlarged and causes significant problems like low blood counts or pain and isn't responding to other treatments. Radiotherapy is mostly palliative, used to shrink bulky lymph nodes causing symptoms or sometimes for splenic irradiation.
Right. So just to quickly recap relapse management. Treat if symptomatic. Consider repeating first line if relapse is late. Switch therapy if early relapse or refractory. And allo-SCT is an option for high-risk cases.
That sums it up well.
Okay, so what's the overall outlook? What's the prognosis for someone diagnosed with CLL?
It's highly variable. That's the main message. It depends heavily on the stage at diagnosis, those genetic features we discussed like TP53 status, the patient's age and fitness, and how they respond to treatment.
So it can range from very slow to more aggressive.
Exactly. Many people live with CLL for many years, often with minimal impact on their daily lives, especially if diagnosed at an early stage. It's often described as indolent. But for others, particularly those with high-risk features, it can progress more rapidly and require treatment sooner.
You mentioned some European survival stats earlier.
Yeah, the 5-year survival rates give a sense of the range. For men, it was something like 42% to 80%, and for women, 50% to 82%. That variation reflects the heterogeneity of the disease.
So staging Rye or Binet and genetics are key prognostic factors.
Absolutely, along with things like lymphocyte doubling time and response to therapy. There are also integrated prognostic scores, like the CLL-IPI, International Prognostic Index, that combine several factors to give a better risk estimate.
Okay. A variable but often long course. Finally, what are the potential bumps in the road? What complications can arise from CLL or its treatment?
One of the major issues is increased susceptibility to infections. That's because the immune system is compromised both by the CLL itself, those dysfunctional B cells, and often by the treatments used.
Infections are a big risk. What else?
Autoimmune complications are quite common. The malfunctioning immune system can turn on the body's own cells, causing things like autoimmune hemolytic anemia, where red cells are destroyed, or immune thrombocytopenia, ITP, where platelets are destroyed.
The immune system attacking itself.
Yes, happens in maybe 10–15% of patients with things like warm autoimmune hemolytic anemia.
And you mentioned Richter's syndrome earlier.
Yes, Richter's transformation, or Richter's syndrome. This is a serious complication where the CLL transforms into a much more aggressive type of lymphoma, usually diffuse large B-cell lymphoma.
How common is that?
It occurs in around 5–10% of CLL patients over the course of their disease. The memory tip was, Richter is Reiter, as in more aggressive, needing urgent, different treatment.
Richter's Reiter. Got it. Any other major complications?
There's an increased risk of developing secondary malignancies, other cancers, both other lymphomas and solid tumors.
An increased risk of other cancers, too.
Yes, that's an important long-term consideration. Also, hypogammaglobulinemia, low levels of normal antibodies, is common and contributes to the infection risk. Rarely, with very high white counts, you can get hyperviscosity syndrome, where the blood gets too thick. And of course, treatment side effects are a potential complication of any therapy.
Okay, so infection risk, autoimmune problems, Richter's transformation, second cancers, and treatment side effects are the main things to watch out for.
That covers the key complications, yes.
All right, well, that brings us towards the end of this pretty comprehensive deep dive into chronic lymphocytic leukemia.
Yeah, we've definitely covered a lot of ground from the basic definition and causes, right through to the nuances of staging, treatment, and potential problems, all based on those core revision notes.
Hopefully walking through it like this, focusing on the high-yield points, has helped to make it a bit clearer and more memorable for your revision.
We hope so. Understanding these fundamentals is crucial.
Absolutely. And maybe a final thought for everyone listening to ponder. Given that CLL is often so slow-growing, that indolent nature we talked about, how do clinicians and patients navigate that decision about when to start treatment? Balancing the risks of the disease progressing versus the side effects of therapy, especially when someone might have years of good quality life on watchful waiting.
That's a really important point. It highlights the complexity of managing CLL and the importance of shared decision-making. There's often no single right answer, and it's an ongoing area of discussion and research.
Definitely something to think about.
And if you're looking for more resources to help with your MSRA preparation, do check out pastthemsra.com and our sister site, freemsra.com.
Great resources. Thanks for joining this deep dive.
My pleasure.